About bone tissues. We talked about the skeletal system that's made of mostly bone tissue. Now we're going to talk about the way that bones are joined together. We call them joints or articulations. And a joint or an articulation is any point where two bones meet. That doesn't mean there's a movable interface there. The science of joint structure, function, and dysfunction is called arthrology, and kinesiology is the study of musculoskeletal movements. Joint names typically are derived from the names of the bones that are involved, for instance, the radio-ulnar joint, and they're often classified according to the manner in which the bones are bound to each other: bony, fibrous, cartilaginous, or synovial joints. So a bony joint or synatosis is an immobile joint formed in the gap between two bones that ossify, and the bones become, in effect, a single bone. So the left and right frontal and mandibular bones in infants are going to ossify. The ilium, the ischium, the pubis fuse to form the hip bone in an adult. The attachment of the first rib and the sternum with old age becomes a joint. And the parietal bones, along with the sagittal suture, form as we get much older. They can occur in either a fibrous or cartilaginous joint. In a fibrous joint or synarthrosis, the adjacent bones are bound together by collagen fibers emerging from one bone and penetrating into the other. There are three kinds of fibrous joints: a suture, a gomophos, and a syndesmos. So we have sutures in the skull, gomophos holding the teeth in place, and a syndesmos, for instance, between the radius and the ulna, and the tibia and the fibia. Sutures are immobile or slightly movable fibrous joints, which short collagen fibers bind the bones of the skull together. There's serrated sutures, an interlocking wavy line. We saw those with the coronal, the sagittal, and the lambdoid sutures. A squamous suture is overlapping beveled edges. The temporal and the parietal bones are held together that way. And in a butt or plane suture, we have a straight non-overlapping edge. Palatine process of the maxillae is an example of that. A gomophos is the attachment for a tooth and its socket. It's held in place by the periodontal ligament, with collagen fibers attaching the tooth to the jawbone. That allows the tooth to move a little under the stress of chewing. In a syndesmos, a fibrous joint in which two bones are bound by long collagen fibers, separation of the bone and length of the fibers make this joint a little more mobile than a suture or gomphosis. Interosseous membranes are a good example. The membrane between the tibia and the fibia allows for less movement than that between the ulna and the radius because of supination and pronation, and it has to do with the length of the fibers involved. Cartilaginous joints are amphithrotic joints. Two bones are linked by cartilage, and they can either be a synchondrosis or symphysis. A synchondrosis, the bones are joined by hyaline cartilage, so there's a epiphyseal plate and a form holding the long bones together as they are growing. That would be, at the time, a synchondrosis. And additionally, the first rib's attachment to the sternum is through a synchondrosis. At symphysis, two bones are joined by fibrocartilage, and the pubic symphysis is a good example of that. The right and left pubic bones are held with an interpubic disc. All of the bodies of the vertebrae are held by intravertebral discs, and they only allow for slight movement, but with all of them, it gives you considerable flexibility. Synovial joints or diathroses, joints in which two bones are separated by a joint cavity. These are the most familiar type of joint. They are the most freely movable, most structurally complex type of joint, most likely to develop painful dysfunction. Most important joints for physical and occupational therapists. athletic coaches, nurses, and fitness trainers, and it's their mobility that makes them very important to our quality of life. All synovial joints have some general structure. Surfaces of the bones are covered with articulate cartilage, hyaline cartilage, 2 to 3 millimeters thick, covering the face of the two bones that are nearly touching. There will be a cavity, a joint cavity or articular cavity, separating the two articular surfaces. And in that cavity is a lubricant of synovial fluid, which is rich in albumin and hyaluronic acid. It's a viscous fluid with a slippery texture, sort of like raw egg whites. It also nourishes the articulate cartilage and gets rid of the waste and makes the movement of the synovial joint nearly friction-free. They have a joint capsule or articular capsule of connective tissue that encloses the cavity and retains the fluid. It's an outer fibrous capsule, which is continuous with the periosteum of the bones, and an intercellular synovial membrane composed of fibroblasts that secrete the synovial fluid and macrophages that remove debris from the joint cavity. Joint capsules and ligaments are well supplied with laminar corpuscles and other sensory receptors, and that enables the brain to monitor limb movements. Here is a simple synovial joint. In a few synovial joints, fibrocartilage grows inward from the joint capsule to form a pad between the articulating bones. That would be an articular disc, which the pad crosses the entire joint capsule. In the temporal mandibular joint, we have one of these, in the clavicle, and between the ulna and the carpal bones. A meniscus is more of a crescent moon-shaped pad that doesn't cross the joint entirely. They're found in the knee, and each pad is called a meniscus. They are there to absorb shock and pressure, but also to stabilize the joint and help guide the bones across each other and improve their fit together. Accessory structures found with synovial joints include the tendon, which is a strip of cartilaginous tissue attaching muscle to bone. Ligaments is a strip of cartilaginous tissue attaching one bone to another. We also have bursa, which are fibrous sacs filled with synovial fluid located between muscles where tendons pass over a bone or between the bone and skin. They serve as cushions, help the tendon slide more easily, and modify the direction of the tendon pull. A similar structure would be a tendon sheath or synovial sheath, which is an elongated cylindrical bursa wrapped around the tendon, and these tend to be abundant in the hand and foot. Long bones act as levers to enhance the speed or power of limb movements. So we got to do a little bit of physics here. A lever is any elongated, rigid object rotates around a fixed point, and that point is called the fulcrum. The rotation occurs when an effort is applied to overcome resistance, which we would refer to as the load at some other point. The arms of a lever are described relative to the fulcrum. The effort arm is the portion of the lever between the fulcrum and the point of effort. The resistance arm is the portion of the lever between the fulcrum and the point of resistance. So in the body, that fulcrum is going to be the joint that we're talking about. And the effort is going to be applied by a muscle, and the resistance is the object you're trying to move. There are two kinds of advantages you can get from a lever. You can exert more force against a resisting object than force applied to the lever, so we can move a heavy object with the help of a crowbar, for example. Or you can move the resisting object farther or faster than the effort arm is moved, like this would be like rowing a boat. The trick is that a single lever can't have both advantages. If you increase one, you decrease the other. So when we talk about the mechanical advantage of a lever, it's the ratio of its output force to its input force. And that mechanical advantage is calculated from the length of the effort arm divided by the length of the resistance arm. So if the mechanical advantage is greater than 1, the lever produces more force but less speed. If it is less than 1, it produces more speed or distance but less force. So, for example, the contraction of the biceps brachii muscle puts more power into the lever than we get out of it, but the hand moves faster and further than the spot of bicep attachment. Mechanical advantage is less than 1. There are also 3 different classes of levers which depend on where the fulcrum is placed. Classification of levers changes as it performs different actions. So forearm is a 3rd class lever when we flex at the elbow, but 1st class lever when we extend it. The mandible is a 2nd class lever when we open the mouth, but a 3rd class lever when we close it. And in a 1st class lever, the fulcrum is in between the effort and the resistance. In a 2nd class lever, the resistance is between the fulcrum and the effort. And in the 3rd class lever, the effort is between the resistance and the fulcrum. And most of the joints of the body are 3rd class lever. But remember, that depends on the movement you are talking about. Range of motion is the degree of which a joint can move. That's determined by the structure of the articular surfaces, the strength and tautness of the ligaments and joint capsules, and the action of the muscles and tendons. Moving a bone has a relatively short stationary axis of rotation that passes. Our axes of rotation are moving a bone has a relatively stationary axis of rotation. They can be a multi-axillary joint, such as the shoulder joint. We can get lots of degrees of freedom or lots of axes of rotation, depending on how you look at it. And other joints are monoaxial or biaxial. There are 6 types of synovial joints, which differ by shape of the articulate surface and degrees of freedom. All 6 can be found in the upper limb. They're in their order of descending mobility, so more mobility in a multi-axial, little less in a biaxial, and even less in a monoaxial. Ball and socket are multi, condylar, saddle, plane, bi, and hinge and pivots mono. Ball and socket joints have a smooth hemispheric head that fits within a cup-like socket. They are the only multi-axial joints in the body. The shoulder and the hip are both ball and socket joints. The structure of the ball and socket is much different in the shoulder than it is in the hip, which is why we have a greater range of motion in the shoulder than we do in the hip. We could also have ellipsoid or condylar joints, where an oval convex surface of one bone fits into a complementary shaped depression on the other. These typically are biaxial joints. They allow movement in 2 planes. Radiocarpal joint, metacarpal phalangeal joints. Saddle joints, both bones have an articulate surface that's shaped like a saddle, one concave, the other convex. These are biaxial joints. The opposable thumb joint is a good example of this. Gliding or plane joints, we have a flat articular surface with a bone slides over each other. These are usually biaxial joints. They're between the carpal bones of the wrist, the tarsal bones of the ankle. In a hinge joint, one bone with a convex surface fits into a concave depression of another bone. And a great example of this is the elbow. Pivot joints, a bone spins on a longitudinal axis. This would again be monoaxial, and the joint between C1 and C2 and the radio-ulnar joint are good examples of this. Terms for joint movement, often in pairs or groups with opposite meanings. The action term refers to the person standing in anatomical position. Each joint is in its 0 position. Joint movements described as deviation from the 0 position or returning to it. For example, flexion is a movement that decreases the joint angle. whereas extension is a movement that straightens a joint and returns the body part to the zero position. Flexion and extension are very common at hinge joints. Hyperextension is extension of the joint beyond the zero position. Now, this is often thought of as a pathological thing, but there are some joints that allow for hyperextension. Abduction is the movement of a body part in the frontal plane away from the midline of the body. Hyperabduction, raise your arms over your back or front of your head. Adduction is the movement in the frontal plane towards the midline. Hyperadduction be like crossing your fingers or crossing your ankles. Elevation and depression, movement raises or lowers the body part within the same plane, as is shown in the shoulders. Protraction, the anterior movement of a body part in a transverse plane. Retraction, posterior movement. Circumduction is to make a cone shape movement, things like you can do with your arm. Rotation is a movement in which the bone spins on its longitudinal axis. It could be medial or lateral rotation. Supination and pronation are found in the forearm. Supination is the forearm movement that puts the palm toward the face anteriorly or upward. That would be anatomical position. And pronation is movement that turns the palm to the face either posteriorly or downward, and in those cases, remember the radius spins, crosses the ulna, and this is not anatomical position. In the hands and digit, we have some special movements: radial adduction, radial abduction, thumb moves away from the hand. Palmar abduction, thumb moves away from the plane of the hand. Opposition and reposition. In the foot, we have some special movements. Dorsiflexion elevates the toes. Plantar flexion extends the toes. So the plantar flexion is used to get your car going faster. Dorsiflexion used to take your foot off the accelerator. Inversion, we turn the soles medially, and eversion, we turn the soles laterally. We spoke briefly last time about the temporomandibular joint, the TMJ. That is a synovial cavity. It's divided into superior and inferior chambers by an articular disc. There are two ligaments that support the joint: the lateral ligament that prevents posterior displacement, and the sphenomandibular ligament on the medial side. A deep yawn or strenuous depression can dislocate the TMJ. Condyles pop out of the fossa and slip forward. It's relocated by pressing down on molar teeth while pushing the jaw backwards. TMJ dysfunction is a cluster of disorders which affect 20 to 30% of adults worldwide. You get clicking, popping, grating noises, restricted jaw movement, pain that intensifies with chewing or yawning, pain medication, behavioral therapies to reduce anxiety, depression, and stress could be used for these. The shoulder joint, or the glenohumeral joint, is the spherical head of the humerus articulates with the glenoid cavity of the scapula. It is the most freely movable joint in the body. Because of the shallow glenoid cavity and the loose shoulder capsule, we get lots of freedom of movement, but we sacrifice stability. The fibrocartilage ring that makes the glenoid cavity a little bit deeper is called the glenoid labrum. There are supporting structures like the stabilizing anterior biceps brachii, long head tendon. There are tendons of four muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, that fuse and form what we call the rotator cuff. And there are five principal ligaments called the glenohumeral ligaments: the coracohumeral ligament and the transverse humeral ligament. 4 bursa at the shoulder: subdeltoid, subacromial, subcoracoid, and subscapular. Very complex joint, unfortunately easily dislocated. Again, that freedom of movement is traded for stability. Anterior dislocation is the about 95% of cases when the shoulder dislocates. Occurs when the arm is abducted and then receives a blow from above. That can damage nerves and blood vessels that pass through the axillary region. The elbow joint has 2 articulations, the humeral ulna and the humeral radial joint. Both articulations are enclosed in a single capsule. There's an olecranon bursa on the posterior side of the elbow that eases the movements of the tendons, and a radial lateral collateral ligament, and an ulna medial collateral ligament that restricts side-to-side motions. Elbow region also contains a proximal radial ulna joint, but it's not involved in the hinge part. The head of the radius fits into the radial notch of the ulna. It's held in place by the annular ligament, which encircles the radial head, and that allows the head to rotate when you are going between pronation and supination. Supination, not super. The hip joint or coxal joint, the head of the femur inserts into the acetabulum of the hip bone. This is a very deep socket by comparison to the shoulder. There's a fibrocartilage acetabular labrum, making the socket even deeper, so we get very few dislocations, and we trade that stability for range of motion. You can do a lot more with your shoulder than you can with your leg. There are associated ligaments, the iliofemoral and the pubofemoral ligaments on the anterior side, the ischiofemoral ligament on the posterior side. The transverse acetabular ligament bridges a gap on the inferior margin, and the round ligament, or the ligamentum teres, is the fovea capitis to the acetabulum. It has an artery that supplies blood to the head of the femur. In the knee, a very complex joint, we have a tibiofemoral joint. Flexion and extension are allowed, but it's also capable of slight rotation and lateral gliding during flex. The patella and the patellar ligament articulate with the femur to form a gliding patellofemoral joint. The joint capsule encloses only the lateral and posterior aspects of the knee. The anterior aspect is covered by the patellar ligament and the lateral and medial patella reticunacula. It's stabilized by the quadricep tendon in the front and the tendons of the semimembranous muscles in the back. There are additional structures associated with the knee. We have lateral and medial menisci joined by the transverse ligament that act as shock-absorbing cartilage. The posterior popliteal region is supported by the extracapsular ligaments and the intracapsular ligaments, which include the ACL that you may have heard being torn. The anterior cruciate ligament is an intracapsular ligament, as well as the PCL, posterior cruciate ligament. Those cross to make an X deep within the knee joint, and the cruciate ligaments are named for the sites of attachment. ACL prevents hyperextension. PCL prevents posterior displacement of the tibia relative to the femur. There are at least 13 bursa associated with the knee, 4 in the anterior, several in the popliteal, and 7 more on the lateral and medial sides of the joint. The knee is highly vulnerable to rotational and horizontal stress. Common injuries include tears to the meniscus and the anterior cruciate ligament, the ACL. Because of the blood supply to these, they heal very slowly, often have to be repaired surgically. Arthroscopy is a procedure in which the interior of the joint is viewed with a pencil-thin arthroscope inserted through a small incision. leads to less tissue damage than conventional surgery, faster recovery. Arthroscopic ACL repair takes about 9 months for healing to complete, typically. The ankle joint, talocrural, includes two articulations: the medial joint between the tibia and the talus, the lateral joint between the fibula and the talus. Both articulations are closed by a single joint capsule. The malleoli of the tibia and fibula overhang the talus on either side. That helps prevent side-to-side motion, gives us more restricted range of motion than we have in the wrist. The ankle ligaments include the anterior and posterior tibiofibular ligaments, the medial deltoid ligament, the lateral collateral ligament, the calcaneal or Achilles tendon. Sprains, torn ligaments, and tendons are common at the ankle, pain and swelling accompanying them. Quite a collection of ligaments and tendons holding that ankle together. Arthritis. Arthritis is a broad term for pain and inflammation of the joints. It is the most common crippling disease in the United States. If you are a physician who handles arthritis, you are a rheumatologist. Osteoarthritis is the most common form of arthritis, often thought of as a wear and tear arthritis that results from years of joint use. The articulate cartilage will soften and degenerate. Bone spurs can develop on exposed bone, causing pain, usually accompanied by crackling sounds that are known as crepitus. Osteoarthritis typically gets better as you use the joint, so you wake up feeling badly, but as you start to move, you tend to come out of it some. Rheumatoid arthritis is an autoimmune attack on joint tissues, and that we'll get into a little more in a second. Arthroplasty is a replacement of a diseased joint with an artificial joint prosthesis. Rheumatoid arthritis, as I said, is an autoimmune attack. Misguided antibodies known as rheumatoid factor attack synovial membranes. Enzymes in the synovial fluid degrade the articulate cartilage, and the bone can begin to ossify, leading to, if it's not treated, ankylosis, which is a solidly fused, immobilized joint. Remissions can occur. These tend to, like many autoimmune diseases, wax and wane. Steroids, aspirin, non-steroidal anti-inflammatories are the first line of defense, and then often steroid-based anti-inflammatories, but I will say that there are many bioactive medications that are making great progress on the treatment of rheumatoid arthritis. Can also replace that joint with arthroplasty. Here is what used to be a very common image of older people with rheumatoid arthritis in the hands and lost their mobility. This is becoming less common with the development of much better medications to treat autoimmune diseases in general, but rheumatoid arthritis in particular, things like TNF inhibitors. All right, that wraps up the joints and wraps up our discussions of the skeletal system. Homework should be posted now.